So I will talk about, my topic is laser rotor orbital IVL. Where do I choose one over the other? So I'll show some examples. These are my personal preferences. So this is completely about where I choose. So this is not guideline based perhaps. So I'll start with an example. So you can see this is a RCA, and a lot of filling defects, looks calcific, and this is an RAO view. So I tried with wires, multiple wires. You can see this is clearly begging for a rotor. This is a tough lesion, unable to cross. Eventually managed to cross it with balloon support, but a 1.25 centimarker balloon would not cross with a lot of guide backing. So therefore, you're looking to rotor this. So I try to gently dilate it very carefully, bearing in mind I don't dissect it, and that will stop me from rotablating. And then I put a microcatheter, slightly wedged it, and the microcatheter would not cross, so therefore I thought I would park the microcatheter, remove the wire, and just pass a rotor wire, which then will do the trick. So try to take the rotor wire, and I will wait. You can see here the rotor wire has come, but the rotor wire is not crossing, and this is when you start clenching your bum because you don't know whether you'll take the wire back. So thankfully, the wire, I took a normal wire because I have already wedged the vessel. There is no flow. The patient is getting chest pain, and therefore I cannot leave the microcatheter for too long. So therefore, the microcatheter was removed after passing the first wire that went through. Over the normal wire, this is when we took the laser catheter. This is an ELCA 0.9 catheter, and this is an ideal indication when I would take laser, which is wire through, but no kit will go through, and therefore you cannot do anything other than take a laser. So what would we have done had we not had laser? Traditionally, perhaps we'd have put some balloons, we'd have done some grenadoplasty, rupture a few balloons, dissect it nicely, but you cannot carry on with the angioplasty. You probably want to bring them back on another day. But laser allows creating a channel or perhaps modifying the lesion to allow a microcatheter. And that's what we managed to achieve. And once the laser modified the lesion, we were able to take a microcatheter, rotor wire, drilled it with a 1.5, upsized it with a 2 because there was quite a lot of calcium, as you saw. And once we had adequate debulking, took an angiogram. You can see still a big tract created with a 2 burr, but still that nodule remains. And that nodule ain't going to go with another 2 or 2.2 burr if you have it. So we decided to take lithotripsy to try and modify it. Here we're not debulking. Once lithotripsy is done, we managed to dilate it, and here we got a very pleasing result. So this is a rollotripsy, a combination of rotablation, laser, and lithotripsy. This has become a frequent norm nowadays because we use a lot of combination because one catheter may not completely do the job. Another example, this is a case of lithotripsy. I don't have the IVUS images, but this patient, luminally, there was not much calcium. It was all more abluminal, quite significant calcium. And this is with a lithotripsy balloon at the proximal lesion. You can see here, I hope you can see my cursor. Probably not. So you can see this lesion was not yielding there. This is after 2 IVL balloons after having exhausted all the pulses from there. So we just finished with 4 IVL balloons. We just had to deliver 4 IVL balloons in the same location to try and expand that lesion, and that is what achieved adequate modification to allow a stent. You can see here very pleasing result. Patient, of course, went into AF at the end of the procedure, but a very nice result. That lesion was well modified proximally. This is another example. This is a CTO. You can see here fairly calcific. Here you can see before the contrast goes in, you can see the black shadowing. So 2 views just to demonstrate. I'm not going to show the CTO recannulation process. That's not the remit of the talk, but managed to get through the distal vessel and then rotate it, and then decided to use Orbital because we started with a 6 French guide. I didn't want to upsize the guide and therefore wanted to have a bigger mean stent area, so therefore decided to adequately debulk with a Orbital, which hopefully should get at least 2 millimeters if we stay long enough and orbit enough number of times. And of course, to finish, because it's abluminal calcium, use lithotripsy also. This is a combination of orbital and lithotripsy, finally achieving a pleasing result. Quite a lot of stents, but you can see, thankfully, this is a dual ostium left main, LAD, and bifurcation was reconstructed with the final result. So this is a rotorlith. We used rota, orbital, and lithotripsy. What about instant restenosis? Instant restenosis, if it's nice and juicy, you can cut it, which often is the case, but sometimes you end up having calcific instant restenosis. I'm just going to show you an example. You can see here, this is the IVUS for that patient. If you didn't see the angiogram, I just want you to note here, you can see the stent and significant instant restenosis. And this is the IVUS showing quite a lot of calcium. Let us just wait for the IVUS to come proximally. You can then see the stent and appreciate the stent and the instant material. I hope you can see here, you can see the stent, and inside the stent you can see the calcific instant restenosis. This is instant restenosis tissue, but it's calcific. This is a 14-year-old stent. We don't know the stent make and model, but it was done somewhere and it's got quite a lot of calcium. Now, whatever we try and do to try and modify this, we are not going to get a good mean stent area because we are going to invariably sandwich this stent, this calcium between 2 stents, and therefore it's unlikely one is going to get adequate stent area. Therefore, decided to debulk it, and because we were on a 6 French catheter, we went with an orbital. Now, orbital, of course, contraindicated inside the stent, but it's a relative contraindication because this is a chronic stent. It should be endothelialized, so we thought we should be able to adequately debulk it. So used orbital, spent a lot of time, tried to debulk the entire stent, in-stent calcific restenosis, spent a lot of time, allowing enough time for the orbit to achieve the 2 millimeter mean luminal area before we stented it. And once we finished everything, stented it, and this is the final result, achieving a pleasing angiographic result. This is the OCT. You can see here the cross-section on the top right-hand corner and the 3D rendering showing a very pleasing result and a good mean stent area. So coming back to the original question, where do I choose one over the other? So I look at them as 2 different classes, either the lesion modifiers or lesion debulkers. So how do we decide? We need to know what debulks and what modifies. Debulking technologies, Rota obviously debulks because it churns them. You remove material and it's flushed off. Orbital, again, removes material, so you're debulking. Laser, yes, it will remove if it's non-calcific because it fumigates them. So it just passes away in the small bubbles pass away if it's soft material. If it's non-calcific, it's not going to debulk. What are the lesion modifiers? IVL is not a debulking technology. It is going to only modify. So therefore, if you modify and if you're going to achieve adequate stent area, then that's fine. But often with significant calcium, you may not achieve adequate MSA. And laser, of course, it's for calcific lesion, it's a modifier because you achieve big explosions, almost 50, 60 atmospheres if you use contrast along with lasing. Therefore, my procedural endpoints for all PCIs that determine what I choose is largely based on what's the best MSA or MLA that I want to achieve. That depends on the vessel size and what is the best outcome I'm going to achieve. I want no potential areas of flow turbulence. If you're going to have a big nodule, if you're going to have flow turbulence, that's going to give you an early TLR. And of course, stent expansion. If the stent at 2.5 doesn't get a 2.5, it's unlikely we're going to have good long-term results, and it's better to debulk and prepare the vessel well before the stent goes in. And therefore, my choice is based on what I see, and of course, usually it is a combination. With that, I shall finish. Thank you.